we're going to talk about ENT and some opto views, some objectives of this small talk, typical ENT and opto examinations, as well as viewing some images using ultrasound, obviously. And we talk about some cases that are normal as well as abnormal. So first things first, you're going to use a high frequency probe. We have two probes, linear as well as your endocavitary probe. All right, so first examination we're going to talk about is the eye exam. A lot of people don't use the eye exam as much, at least in the ER, but we should because it's very easy and simple. So everything in ultrasound, you're going to use or visualize the structure in two views, especially the eye. You're going to put lots of gel, first on tegaderm, then on the eye itself, and we look at both the transverse as well as the sagittal views. All right, a lot of times you want to minimize pressure on the eye itself. So use your fingers to put more pressure on the nasal bridge as opposed to the eye. And remember, lots of gel, and lots of gel. Okay. On the right-hand side of the screen, you'll see the normal anatomy that you should be looking for, your anterior chamber, your vitreous body, as well as your retina, which is posterior, and your optic nerve sheath, which is this hypoechoic band right posterior to the retina. Okay. At any time, if you have any questions or want me to stop, just let me know. So anteriorly, you're going to see your eyelid. You're going to see your anterior chamber, your lens, which is hyperechoic, which is posterior to your anterior chamber, your retina, and then your optic nerve sheath. By default, we usually measure at 3 millimeters back from the retina, and then we measure across. Should be less than 5 millimeters. All right. In some cases, this could be normal. But when assessing for increased intracranial pressure, this might be helpful, although specificity runs between 70 to 80, so not the best. But there are other things that you can use that are a little bit better. So our first case today, we're looking at the eye. Can anyone say or tell me if this is normal or abnormal? Anyone?
Abnormal.
Abnormal, good. If you think it's abnormal, what do you think it could be? Any guesses?
Retinal detachment or vitreous hemorrhage.
Yeah, retinal detachment with vitreous hemorrhage. So good. So this is a sign of retinal detachment. Okay. What we notice here is that we're looking at the anterior chamber, we're looking at the vitreous chamber, but most importantly, the retina, which is posteriorly. But you see how this hyperechoic structure, which is the retina, which is lifted up, it's always tethered to the optic nerve sheath, and it creates like a V. All right. So when you see that V and it's tethered to the optic nerve, it most likely is retinal detachment. All right. Once again, looking at the hypoechoic line, this is the retina which is lifted up, but always tethered to the optic nerve sheath. Okay. What about this? This is another case. Patient comes in with blurry vision. What do you guys think? What do you think this is? No answers. Want to give you some help?
The
It's the other.
posterior chamber?
Was that?
The posterior chamber? Is there something?
Yeah. Yeah. What do you think that is?
Mm,
Well, we heard it before, is vitreous detachment.
Interesting.
Yeah, so remember we talked about retinal detachment? That thin membrane is going to be tethered to the optic nerve sheath. Compared to vitreous detachment, that membrane, which is the vitreous, it's uplifted and it's going to be past or beyond midline or above the optic nerve sheath. So if you see that it's all the way above the optic nerve sheath, then that means it's a vitreous attachment. If you see it's tethered to the optic nerve sheath itself, or the nerve, that means it's a retinal detachment. So that's an easy way to distinguish vitreous versus retinal detachment. All right, what about this case? What do you guys think? Looks a little bit weird. What do you guys think? I'll give you hints. This person was punched in the eye. Oh, oh, oh. Globe rupture. Yeah, globe rupture. Very good. So this is a sign of a globe rupture. Oh, So normal versus abnormal globe rupture. So normally we see the anterior chamber, posterior chamber, and vitreous chamber. Compared to the globe rupture, you're going to see buckling of the sclera, you're going to see loss of the anterior chamber, and you can see contents within the vitreous chamber. All right. So obviously in patients who have trauma, this is controversial because you don't want to put so much pressure on the eye. However, in some cases where the eyelid is very close and therefore you can't visualize the eye itself, sometimes placing lots of gel, less pressure on the eye itself by placing your fingers on the nose bridge, you can visualize the eye through the lids, and you can see this, and this will give you a hint of whether to get ophtho immediately versus waiting for a CAT scan. And in this case, you would get ophtho immediately. All right. So what about this image? We see something, I'll give you a hint, abnormal.
IIH.
Yeah. Yeah, or optic nerve sheath diameter. Optic nerve sheath diameter is elevated or increase. So remember, we always measure the optic nerve sheath 3 mm back from the retina and across this hyperechoic band that you see. So anything above 5 mm is abnormal. Although I would say it's not as specific because in some patients you could have the optic nerve sheath with this abnormal, but still have no signs of intracranial elevation. So what is a little bit, and this is once again where to measure it and how to measure it, what is a little bit more specific is optic disc elevation, which correlates to papilledema. So noticing that the retina, we see some elevation at the level of the optic nerve sheath, and anything above 0.6 mm is pretty specific for increased intracranial pressure. So it's much more specific compared to the optic nerve sheath diameter by itself. All right, there are other measurements you can use, such as the optic nerve sheath diameter to the external transverse diameter of the orbit ratio, and that's also specific for increased intracranial pressure. All right, so that was the eye, just a quick breakdown of the eye. Next is the ENT exam, and we're looking at using the endocavitary probe. So fun note, this is a previous, on the left-hand side of the screen, a previous ultrasound director, Dr. Secco, with the endocavitary probe in the mouth. And then also on the right-hand side of the screen, an actual patient with looks like looking at the peritonsillar space using a Miller blade. Sometimes I'll use a macro Miller blade for light as well as to improve visual visibility of the oropharynx. You could also,
Do you usually use a probe cover when you use it?
sorry?
You use a probe cover when you use it orally?
Yes. Just like any other examination, it's going to be used once and it's going to be sterilized. So I would use a probe cover. You just have to put a lot of gel on and decrease the amount and increase the amount of tension within the probe so that you don't have any air interface. Otherwise, it'll decrease the visualization of the tonsils. Another approach that you can use, especially in patients who have like trismus, because these patients will have decreased ability to open the mouth, is the extraoral approach. On the left-hand side of the screen, you have your linear probe. You're going to go just below the submandibular area or the mandible, and you're going to aim your probe up towards the head. And this is what it looks like. You have your left-hand side of the screen. We have the extraoral approach with your tonsils in the far field, but you have your endocavitary approach where your tonsils are abutting the actual probe, and then you have the tonsils in the near field. So what's not seen or visualized in these two images is the carotid artery. You always want to look for the carotid artery before you poke anything because you want to make sure you stay clear of the carotid artery. So always avoid the carotid artery when visualizing or trying to visualize the tonsils. Okay, this is another example of using an endocavitary probe. Notice that in the near field, we have a large heterogeneous collection, which is an abscess. And then the carotid artery is going to be posterior or lateral, and that's how it normally looks like, posterior lateral to the actual like tonsil. So you always want to visualize the carotid artery before you poking it anywhere into the space. All right. Next and last, we're going to look at the trachea. So we're going to use a linear probe to visualize the trachea, and a lot of times we're going to use the trachea view in order to confirm ET2 confirmation. So looking at the trachea, what does it normally look like? At the level just below the cardiac cartilage, we're going to see the level of the thyroid. We're going to see dirty shadowing. and that's the air interface that you see. And then we're going to try to visualize the esophagus, which a lot of times will be empty and won't really have any air interface. So you see shadowing within the trachea. However, in the esophagus, you won't see really that much shadowing, just soft tissue behind it. So ET2 confirmation, we're going to use your linear probe just above the suprasternal notch, looking at the trachea for the rings and looking at the esophagus. All right, and we see our thyroid just anterior to your trachea. So if you see this and you're trying to intubate, you won't really see too much in the esophagus, but most movement within the trachea. All right. However, if we do see movement within the esophagus, which is just lateral to the trachea, that's a double track sign or double trachea sign, and that's bad. We don't want to visualize that. Okay. Because whenever we visualize that, we know that we're intubating the esophagus and not the trachea. We just want to see one single track within the trachea and not the empty esophagus. The only thing is that because the esophagus sometimes is posterior to the trachea, this could be hidden, and therefore you might miss the esophagus, or it could be silent. So in those cases, it's kind of hard, which is why you always need a confirmatory test for endotracheal tube confirmation. So another example of the double track sign, we have shadowing within the trachea. We also have shadowing within the esophagus. Two tracks you don't want to see. You always want to see one tract and shadowing to confirm that you're actually within the trachea. And this is a pediatric patient where we see, and especially for peds, it's pretty easy. So all the structures are very superficial. So you're able to visualize the esophagus as well as the trachea. So if you see two tracks, then that's bad. You need to re-intubate this patient since you're not within the trachea. So other ENT applications which are not discussed, typically you can look at the thyroid gland, looking for nodules, looking for Graves' disease, Hashimoto's thyroiditis. We could look at the cric anatomy and help that for procedures for a cric, looking at lymphadenopathy as well as lymphadenitis, also the salivary glands and other neck masses such as thyroglossal duct cysts as well as abscesses. So in summary, always use your high frequency probe. You want to use or look at the structures in two planes, both transverse and sagittal, either linear or endocavitary. Compare contralateral slides if unsure, especially for the peritonsillar space. Lots of gel for the eye. Always avoid the carotid artery, and double track or trachea sign is very bad. Always want a single track. Any questions so far?